Hello everyone and welcome to our module on peripheral vascular disease. Let's start by talking about carotid artery disease. Carotid artery disease is atherosclerotic narrowing of the carotid artery. And when there are atherosclerotic plaques in the carotid artery, those plaques can ulcerate, a thrombus can form, and the thrombus can embolize to the brain, causing TIA or stroke. Carotid artery disease almost always occurs at the carotid bifurcation. If you look at this drawing on the right side of the screen here, this is the common carotid artery here, and it branches into the internal and external carotid arteries, and that's where plaque usually forms, like what's shown in this image on the screen. Most patients who have carotid artery disease are asymptomatic. Often it is identified because a bruit is heard if you place the stethoscope over the carotid artery in the neck, or sometimes imaging studies are done to screen for carotid artery disease and plaque is identified. Carotid artery disease is considered symptomatic if there's been an embolization, meaning a TIA or stroke, from a carotid plaque within the past 6 months. So that's a nice segue into the clinical features of carotid artery disease. The feared outcome is a stroke. Usually these cause cortical strokes, usually in the MCA territory. So patients can present with symptoms like homonymous hemianopsia, where they can't see half of the visual field, hemiparesis, or hemisensory loss. If the stroke affects the left side of the brain, it can lead to aphasia, and if it affects the right side of the brain, it can lead to spatial neglect. Amaurosis fugax means transient monocular blindness caused by an embolus to the ophthalmic artery, which is a branch of the internal carotid artery, and this can sometimes happen when patients have carotid artery disease. What they will describe when they have amaurosis fugax is a sensation like a curtain shade coming down over one eye. And then, as I mentioned on the last slide, sometimes the narrowing of the carotid artery can cause a carotid bruit, which you can hear on physical exam with the stethoscope. On fundoscopic exam, the classic finding of embolization from a carotid artery plaque is the presence of what's known as Hollenhorst plaques. If you look at this image on the screen, you can see this yellow dot in one of the retinal vessels. That is called a Hollenhorst plaque, and that occurs when cholesterol embolizes to the retinal artery. This can be from a carotid artery plaque. It can also happen if there's plaque embolization from the aorta itself. The most common technique used to make a diagnosis of carotid artery disease is a carotid duplex ultrasound. Ultrasound machines these days are usually portable, and it's very simple to use them to make a diagnosis of carotid artery disease. More advanced imaging techniques are sometimes used, especially if intervention on a carotid plaque is being considered. Things like magnetic resonance angiography. This is an example of one shown here on the screen. You can also do CT angiography. And then finally, invasive angiography can also be used. This is done usually in planning for a carotid procedure, but you can directly inject dye into the carotid artery and take an image of it. We'll talk about medical therapy for carotid artery disease in a minute, but let me first talk about surgical intervention for carotid artery disease. There are two surgical procedures used to treat carotid artery disease. The first one is carotid endarterectomy, or CEA. This is a vascular surgery procedure. It involves opening up the neck and removing the diseased vessel and replacing it with a graft. The other option is carotid artery stenting, or CAS. This is less invasive. It involves placing a stent into the carotid artery that is threaded up from a vessel in the arm or in the groin. And there have been lots and lots of clinical trials comparing CEA to CAS in various groups. And this is still a subject of debate. It's very complex in determining which of these interventions patients should get. And they're not going to ask you about this on your boards. All you need to know is that both of these are treatment options for patients who have appropriate indications. So in terms of management of carotid artery disease, the first thing you want to know is that all patients, no matter what you're going to do in terms of surgery, need to be placed on a statin, an aspirin, they need to have their blood pressure controlled, and they need lifestyle counseling to get exercise, maintain a healthy weight, and not smoke. And don't forget these things on your board exams. Often they'll describe a patient with carotid artery disease, and they're not looking for you to choose a surgical intervention. They're just looking for you to recognize that you need to prescribe basic therapy. Beyond these basic therapies, in patients who are asymptomatic, if the stenosis is greater than 80%, then carotid endarterectomy or stenting are both options. If it's less than 80%, then there's no intervention, it's medical management alone. Symptomatic patients are different, so some symptomatic patients have a 100% stenosis. These patients usually have developed collaterals, and in this case, medical management is all that is needed. If the narrowing is 70 to 99%, then carotid endarterectomy or stenting is indicated. If it's less than 70%, only for men do you intervene because men are at higher risk of stroke. So men with a 50 to 69% narrowing are candidates for carotid endarterectomy or stenting. For everyone else, which means all women with a stenosis 69% or less and all men with a stenosis 49% or less, medical management alone is indicated. Now let's talk about subclavian steal, which refers to flow reversal in the vertebral artery caused by stenosis of the subclavian artery. So to understand this, let's look at this drawing on the screen. This is the aorta right here, and in black here we have the subclavian artery on the left side, but it's occluded. So when this vessel is occluded, how is blood flow going to get to the distal subclavian artery and to the arm? Well, the way this is going to happen is blood is going to go up the vertebral artery on the unaffected side, that's the right side over here, and then down the vertebral artery retrograde on the left side, and that's how the arm will be perfused. Clinically, this is going to cause a couple of problems. First of all, the blood pressure is going to be higher on the right and lower on the left because of this stenosis. There won't be as much blood flow to the left arm as there would without the stenosis, so there will be a blood pressure discrepancy. That's your first clue on physical exam that a patient may have a subclavian stenosis. The second thing that's going to happen is if this patient begins exercising with their left arm, there won't be enough blood flow to meet the oxygen demand because blood flow through this vertebral artery in a retrograde manner is not the same as blood flow through the normal subclavian artery. So when this person exercises and uses their left arm, they may get arm ischemia and may get symptoms like pain or numbness. And then finally, if they exercise with their left arm, they may draw so much blood flow down this vertebral artery that they cause ischemia to the brain, and this can potentially lead to dizziness or syncope. Dizziness or syncope is very rare in patients with subclavian stenosis, but it does sometimes occur, and when it does, we refer to it as subclavian steal. So I've summarized these points in this slide. Patients with subclavian steal have a blood pressure discrepancy, usually more than 15 millimeters of systolic pressure, caused by the subclavian stenosis. They can develop symptoms of exercise-induced arm ischemia. These are symptoms like pain, fatigue, and numbness. And rarely they can develop dizziness or syncope when they use their arm on the affected side. The diagnosis is made by clinical features plus ultrasound of the subclavian artery, and the treatment is to bypass the subclavian artery surgically or to insert a stent. Moving on, let's talk about peripheral artery disease. When we say a patient has peripheral artery disease, what we mean is that they have atherosclerotic narrowing of blood vessels that supply the lower extremity. Most commonly, the plaques develop in the aortoiliac system or the femoral systems, and let's talk about what that means. So if you look at this drawing on the right of the aorta branches into the left and right iliacs, and that's where many patients develop peripheral arterial disease, often involving the iliacs or sometimes the aorta. The other common location is in the femoral artery. So the femoral artery runs from the inguinal ligament down to the popliteal artery, which supplies the lower leg. Patients can develop peripheral artery disease in the proximal portion of the femoral artery, which is called the common femoral artery, or in the distal portion of the femoral artery, which is called the subsartorial artery. All of these areas, which are collectively called the femoral system, are common sites for peripheral artery disease. The main clinical feature of peripheral artery disease is claudication. Claudication is pain that's induced by walking and relieved by rest. When you walk, the muscles of the leg demand more oxygen, and if there is narrowing of the blood supply, that demand cannot be met, and that will lead to muscle symptoms. And the muscles that can be involved could be the quads or the calves or the gluteal muscles. These are the ones that are most commonly involved in claudication. The precise site where the symptoms occur of claudication can vary depending on where the peripheral artery disease is present. So patients who have aortoiliac disease, which is very proximal disease, they often develop symptoms in the buttocks and in the hips with walking. Patients who have common femoral disease, which is more distal than the aortoiliac system, they tend to get claudication symptoms in the thighs or in the calves. And then patients who have disease of the superficial femoral or the popliteal artery, they often get pain that is much more distal in the calves. Other clinical features of peripheral artery disease are shown on this slide. The first one is hairless legs and feet. So to grow hair on your lower legs and on your feet, you need a good blood supply. So one of the first things that happens to patients with peripheral artery disease is they lose the hair on their feet. This is a very common finding in elderly patients. Many of them have undetected peripheral artery disease. And if you want to look like a superstar on your clinical rotations, carefully examine the feet of all your patients. You will surely find hairless feet in some of them. Present this to your preceptor and you'll look like a superstar. Other findings are the skin can become shiny when there's poor blood supply, and the skin can break down, and this can cause the formation of ulcers. And then finally, Berger's sign is evidence of poor blood flow to the feet. What you do is you lie the patient on the table and you raise their leg up to a 45-degree angle. If there is inadequate blood supply, the leg will immediately become pale because the blood flow is not able to overcome the effects of gravity due to poor blood supply. So that's the first part of Berger's sign, is elevation turning the foot pale. Then what you do is bring the foot down and dangle it over the side of the table, and the foot will become bright red. The reason for this is because that when the foot had ischemia while it was up in the air, all the local blood vessels dilated, and therefore when you allow gravity to restore blood flow, the foot becomes bright red. So that's Berger's sign. Elevation turns the foot pale. Dangling it over the edge of the table turns it bright red afterwards. There is a scale that is sometimes used to describe the severity of claudication symptoms. It's called the Rutherford Symptom Scale. Category 0 patients are asymptomatic. Category 1, 2, and 3 patients have increasing severity of claudication, and then Category 4 patients have symptoms at rest, and Category 5 and 6 patients have evidence of tissue loss from ischemia. The most common way we make the diagnosis of peripheral artery disease is by measuring the ankle brachial index. The way this test is performed is shown in this picture on the screen. What you do is you measure the blood pressure at the ankle and you divide it by the blood pressure in the arm in the brachial artery. If there is no peripheral vascular disease, then the ratio of the ankle blood pressure to the brachial blood pressure should be 1, and that's a normal result, is 1. If the blood pressure in the leg is low because of narrowing of the arteries, then the ankle brachial index will become less than 1. And any value less than or equal to 0.9 is abnormal. And you can do this test at rest and with exercise. Some patients have a normal ankle brachial index at rest, but with exercise it becomes abnormal. And then if a patient has an abnormal ankle brachial index, you can then do testing to image the vessels in the legs and try to determine the site of the atherosclerotic narrowing. Many imaging techniques are useful for this purpose, including ultrasound and CT scanning or MRI. This slide shows the major risk factors for peripheral artery disease. Far and away, smoking is the biggest risk factor. The vast majority of patients who have peripheral artery disease are smokers. Other risk factors are shown on this slide. They include diabetes, hypertension, high cholesterol, kidney disease, or a history of coronary disease. When you are treating patients with peripheral artery disease, the most important thing to remember is that their greatest risk to their health is not the narrowing of the blood vessels in their legs, it's their brain and their heart. So patients who have peripheral artery disease have a very high risk of developing cardiovascular disease like stroke or MI. So when you're treating these patients, the first thing you do is administer treatment to reduce their risk of stroke or MI. All these patients need to be given aspirin or clopidogrel. They all need to be on a statin. They all need to be told to quit smoking if they smoke, and they all need to be treated for diabetes and hypertension. Remember this for your board exams. They often want you to know that the greatest risk to these patients is that they will develop a stroke or have a heart attack. The initial treatment for peripheral artery disease and symptoms of claudication is almost always an exercise program. When patients exercise, it stimulates the growth of blood vessels, and patients can develop collateral blood flow to the leg, and their claudication symptoms will get better with regular exercise. There's a drug therapy that is sometimes used. The drug is called cilostazol. It's a phosphodiesterase inhibitor. There's some evidence that this decreases claudication and symptoms, although the evidence is not strong. And then in patients who have significant ischemia to their legs, like lots of claudication symptoms, or maybe damage to the skin and tissue breakdown from poor blood flow, these patients usually need surgical revascularization or stent placement to restore blood flow. Larochet syndrome is a special form of peripheral vascular disease where there's atherosclerotic narrowing of the aorta above the iliac bifurcation. If you look at this image on the screen here, this is the aorta, and it's narrowed here at this portion below the kidneys above the iliac bifurcation. That is consistent with Larochet syndrome. When this happens, patients will develop thigh and hip claudication, but it will be bilateral as opposed to unilateral, which is what is usually seen with peripheral vascular disease. Men can become impotent, and there are usually absent or diminished femoral pulses. And all you really need to know about this syndrome is that it's a rare presentation of peripheral vascular disease, and you need to be able to recognize it. Now let's talk about acute limb ischemia. This refers to a sudden decrease in limb perfusion, and the key word is sudden. In patients with atherosclerotic narrowing of peripheral blood vessels, there is a slow, steady decline in limb perfusion. In contrast, patients with acute limb ischemia have a sudden, abrupt decrease in limb perfusion, often from a thrombosis. This is a potentially life-threatening condition, and there's a very high risk of amputation of a limb being required. There are two reasons patients can develop acute limb ischemia. The first reason is from a thrombosis at a local site within the leg. This can occur at a site of an atherosclerotic plaque, where the plaque ruptures and a thrombus forms. Sometimes patients have aneurysms in the vessels in their legs. We'll talk more about this later, but aneurysms are prone to thrombosis formation. And then finally, if a patient has a hypocoagulable state for any reason, sometimes a thrombus can form in one of the blood vessels of the leg, and that will cause acute limb ischemia. The second reason acute limb ischemia can develop is from a cardiac embolism. So for example, patients with atrial fibrillation can develop a blood clot in the left atrial appendage, and a piece of that clot can break off, travel to the leg, and cause an abrupt drop in limb perfusion to the leg. Also, patients who have an anterior myocardial infarction will have hypokinesis of the anterior wall of the left ventricle, and that can lead to the formation of a clot in the left ventricle, and a piece of that clot can break off and travel to the leg. And shown on the screen is a cardiac MRI from a patient of mine. This is the left ventricle right here, and this dark structure here is a thrombus on the anterior wall. So this patient could easily develop acute limb ischemia if a piece of this thrombus breaks off and travels to the lower extremity. The clinical features of acute limb ischemia can be remembered by the 6 P's. Those P's are pain in the affected extremity, pallor, which refers to pale or mottled skin. If you look at this picture on the screen here, this is an example of mottled skin. This skin rash is sometimes called livedo reticularis. It's a blotchy red, sometimes described as marbled rash. If you ever see this in a patient, it's a very ominous sign. It always means there's poor blood flow to the limb. It could be from limb ischemia, it could be from sepsis, but usually something very bad is going on. The 3rd P is pulselessness. The 4th P is poikilothermia, which basically means that the skin becomes cool from lack of blood flow. The 5th P is paresthesias. Patients can complain of numbness or tingling in limbs with ischemia. And then the 6th P is paralysis. Clinically, acute limb ischemia tends to present in 2 patterns. The first pattern is symptoms of acute limb ischemia in a patient who has a history of claudication or has a history of known peripheral artery disease. These patients usually have a thrombosis at an atherosclerotic plaque in a vessel supplying the legs. And because these patients have a history of vascular disease, they often have some collaterals. So the onset of symptoms can sometimes be slower over the course of hours to days. The second way this can present is in patients who have no history of peripheral arterial disease, meaning no claudication, no imaging in the past that showed peripheral artery disease. In these cases, there's often an embolism present in the heart. And these patients get sick more quickly because they do not recruit collateral blood vessels because they don't have a history of vascular disease. So they can present with very rapid, severe signs of limb ischemia that come on over the course of minutes. The diagnosis of acute limb ischemia is almost always by CT angiogram. CT scans are readily available, and an angiogram can identify the location of the vessel occlusion. Treatments for acute limb ischemia are listed on this slide. First of all patients are given intravenous fluids to generally increase circulation, and the leg is placed in a dependent position so that gravity will pull more blood into the limb. And then patients are administered heparin to decrease clot formation. So these first 3 things are generally given to all patients. These next 3 are variable depending on the severity of the limb ischemia. Things that can be used to restore blood flow include thrombolysis, surgical revascularization, and then finally, if the limb is not salvageable, amputation is necessary. And then this table on the right side of the slide shows one of the commonly used classification systems for acute limb ischemia and how decisions are made on the type of intervention required. So patients who have class 1 limb ischemia have viable tissue. They have mild pain, intact capillary refills, and peripheral pulses. And these patients often don't require any surgical intervention. They can improve with fluids and heparin and things like that. Patients who have class 2A limb ischemia are marginally threatened. There's moderate pain, diminished pulses, there may be a sensory defect. These patients usually require revascularization done urgently but not emergently, meaning it doesn't have to be done immediately when the patient arrives at the hospital. Class 2B patients have immediately threatened limbs, so they have severe pain, sensory and motor deficits, and no pulses. These patients are usually taken for emergent revascularization as soon as they are identified. And then finally, patients with class 3 ischemia have complete paralysis or no sensation. There are signs of dead tissue, and these patients usually need a limb amputation. Let's talk about arterial aneurysms. So an aneurysm is a focal dilation of more than 50% above the normal vessel diameter. If you look at this drawing on the screen, this is a normal blood vessel at the top, and at the bottom is a blood vessel with an aneurysm, and you can see that there's this focal dilation. When patients have peripheral artery disease and atherosclerotic plaque, that plaque can weaken the wall of the vessel, and then the vessel wall can begin to bulge out. And the reason this is a problem is because the blood flow in the aneurysmal portion gets very slow, and that can lead to the development of thrombosis and limb ischemia. The most common location for an arterial aneurysm is the popliteal artery. The second most common is the femoral artery. And these patients present with typical signs and symptoms of limb ischemia, and the diagnosis is usually made by some form of imaging like ultrasound, CT scan, or MRI. Let's talk about pseudoaneurysms now. A pseudoaneurysm occurs when there's a hole through one of the layers in the artery wall, either the intima or both the intima and media. This allows blood to fill the space between layers and causes the vessel wall to bulge outward. This is called a pseudoaneurysm because it does not involve all 3 layers. True aneurysms, like we talked about in the last slide, involve all the layers of the vessel wall bulging outward. In this case, it's only one or two layers which are bulging out from blood underneath. If you look at this drawing on the screen, this shows the structure of an artery wall. Arteries have three layers: the intima, the media, and then the externa, also called the adventitia. If there's a hole in the intima or the intima and media, blood can get underneath the adventitia, and that will push the wall outward and form a bulge. These are usually traumatic, and the most common location is the femoral artery. We insert catheters for cardiac catheterization in the femoral artery, and when we remove those catheters, it often leaves behind a hole in the intima or the media. This will cause a bulge to form in the groin of the patient, which will be obvious when you examine the patient, and that is evidence of a pseudoaneurysm. And unfortunately, Dr. Ryan himself caused a number of these when he was in training as a fellow. These are very common after cardiac catheterization. The diagnosis is usually made by ultrasound, so in a patient who had a recent cardiac catheterization at the femoral artery, who now has a bulge in the groin, the test you want to order is an ultrasound. It can make a diagnosis of the pseudoaneurysm. There are a couple of ways to treat these. Surgery can be done to close the aneurysm. There are stents that can be placed in the femoral artery to close the aneurysm. And then finally, many times you can simply inject thrombin, and this will clot the blood that is between the layers of the vessel wall, and that will seal off the hole, and this will cause the pseudoaneurysm to go away. Finally, we'll talk about atheroembolism to the lower extremity. This refers to embolization of cholesterol from plaque in the aorta that travels to the lower extremity and causes limb ischemia. If you look at this drawing of the aorta on the screen here, many patients have plaque in their aortic arch and ascending or descending aorta. If a piece of that plaque breaks off, it can travel distally and lodge in one of the vessels of the leg and cause limb ischemia. This commonly occurs after cardiac catheterization or vascular surgery. In these procedures, instruments and catheters are often inserted into the aorta, and they can chip off a piece of plaque and cause it to travel distally. This causes all the usual signs of limb ischemia. In addition, it is a classic cause of livedo reticularis, the mottled skin that we talked about earlier. If you see a patient with mottled skin, like is shown on the screen here, following cardiac catheterization or vascular surgery, you should be very concerned that that patient may have developed an atheroembolism. A unique feature of atheroembolism is that it often causes eosinophilia, and therefore the CBC will show an increase in the eosinophil count. And the treatment for atheroembolism is just supportive care. Most patients restore blood flow within a period of time. There are no specific measures that are taken to resolve atheroembolic obstruction of blood flow. And that concludes our video on peripheral vascular disease.